Hello and welcome back to the Ophthalmic Referrals series. My name is Christian, I'm an optometrist, and the aim of this series is to offer some helpful hints and tips to my optometry colleagues in primary care who are making referrals to ophthalmology. In this episode, we're going to talk about vitreoretinal referrals. I would encourage you to watch the first episode in this series, which covers the generic information that we should include in any ophthalmology referral, because that will underpin this entire series. Please remember, this is how I would process a vitreoretinal referral. You must of course use your own professional judgment, and you really must follow any national and local policies, procedures, guidelines which are in effect. If you're unsure, do please seek professional advice. Vitreoretinal specialists are surgeons. They're particularly interested in the vitreous, for example a vitreous hemorrhage, any complications from cataract surgery such as retained lens fragments, and more serious complications such as endophthalmitis. They're also interested in the vitreoretinal interface, so the more anterior retina, and that could be your epiretinal membranes, PVDs and macular holes. You also have that cohort of retinal tears, breaks, detachments, and the associated degenerations and symptoms associated with that. It could be lattice degeneration, it could be flashes and floaters. We should differentiate vitreoretinal conditions from medical retina conditions, and I have a separate talk on that, so please have a look at that if that's of interest. But simple example, pigmented fundus lesions, that's not for the vitreoretinal team, that would be for medical retina. There's a number of clinical case discussion forums out there, and you can just do a simple search online for those. But for some of these vitreoretinal conditions, there's some great discussions and images out there. So OCT discussion and Optomap clinical case discussion. Let's start off with basics. As usual, we're interested in the symptoms that the patient is complaining of. Which eye is affected? How long has it been going on for? How often does it happen? And is it stable? Is it getting better? Is it getting worse? Of course, with a description of what it is they're experiencing. In terms of the clinical signs, again, describe what you see, describe where it is, and do include negative findings. So in the context of flashes and floaters, you'd probably want to record a negative on Schaffer's sign. Did you dilate the pupils? Just to really clarify exactly where your investigations have led you. Imaging is vitally important in vitreoretinal cases. OCT is very helpful in many cases, and in those more peripheral cases, then wide field fundus photos, and if you don't have access to that, then off-axis imaging can be really helpful. It can be sometimes difficult to remember which direction to ask the patient to look in if we're trying to image a lesion, and a simple tip that I found helpful is to ask the patient to look in the direction of where the lesion is located. So if there's a lesion on my temporal retina in my right eye, if I look towards the right, that will bring the lesion around so that it's centered on the camera, or at least moving it in the correct direction. That can also be helpful if you're delegating those images to a member of your team. It's helpful to document the SOS advice that you've given, mainly in the context of flashes and floaters. What should we try to avoid in our Vitret referrals? Well, this is one I've come across a number of times. Routine referral for scleral indentation to exclude a tear. If you think a patient has a tear, or a good chance of having a tear, you want to be referring them much more urgently than that. Scleral indentation, I'm not convinced that that's done a huge amount even by vitreoretinal specialists, so it might be worth being aware of that before you request that. Another example might be, patient has floaters, please rule out anything sinister, but without actually giving really any context to that or what your investigations have revealed so far. So if you could qualify that, for example, with patients presented with floaters in the right eye for the last 3 weeks, no flashing lights, and then to go a step further by saying, for example, good view of both eyes through dilated pupils, Schaffer negative, no tears, breaks, detachments seen, nor other risk factors, but unable to explain symptoms. We really know where we are with that, and the person receiving it can assign a more appropriate time to care. Once we've got the basics right, then we may look to upgrade our vitreoretinal referrals. I'm going to start off by talking a bit about floaters. There's a couple of references at the bottom there from the College of Optometrists. They offer some guidance on examining patients who present with flashes and floaters, and they also include some guidance on referral urgency. So some additional information that you might want to provide in the context of a flashes and floaters referral: a description of what the patient's seeing, so how many floaters, what shape are they static or mobile, and to describe the photopsy. So is it an arc-shaped photopsy or a point photopsy? Were they having a similar onset, or was there some time between them? And any relevant history or risk factors. So as you can see, myopia, lattice, PVD is relevant. Have they had previous intraocular surgery, especially vitreoretinal surgery? Have they had recent trauma to the eye? And anything relevant in the family ocular history. Turning now to macular holes, and I'm really pleased to say that the College of Optometrists have recently produced a clinical management guideline on vitreomacular traction and macular holes. The reference is at the bottom there, so definitely check that out if you haven't seen it already. You want to describe quite specific symptoms here. Have they noticed a reduction in vision themselves? Have they noticed any metamorphopsia or micropsia? And you can confirm that with an AMSLA. Have they noticed any photopsy? It's really helpful to classify it, and that's going to be pretty tricky without an OCT. And a note on referrals here: usually a macular hole at stage 2 or more is processed on an urgent referral basis. The key things here again are whether or not it's flat, and if there's fluid present, then that tends to again push it towards urgent, but stage 2 or more. And the prognosis is worse if it's been there for some time, so typically a year or more. And if the VA is 660 or worse, again, usually the prognosis is worse. But a lot of these patients do have quite a profound reduction in VA, and they recover really well after surgery. And finally, just to talk briefly about epiretinal membranes, we see quite a lot of these. Describing specific symptoms, so have they noticed spontaneously reported distortion? Are they closing one eye to read or to help to sharpen the image? Those key words are actually really pertinent. Any diplopia? Is it getting progressively worse or stable? We should be describing that with any symptoms. And specifically, is it affecting, or how is it affecting, their quality of life and activities of daily living? Plus the severity. A bit like with cataract, the more severely it affects these activities of daily living, the more likely they are to want to go ahead and proceed to surgery, and the easier it is to justify that decision. Although a lot of epiretinal membranes are either idiopathic or secondary to a posterior vitreous detachment, I just wanted to take this opportunity to remind you that there are other more serious potential causes. So retinal vascular disease, ocular inflammatory disease, intraocular tumours and retinal tears and detachments. Just keep those at the back of your mind. And a note on referrals: if the VA is good, they're unlikely to operate because the risk outweighs the benefit. And the criteria will vary from one area to another. Typically it's around the 612 or even 618 mark, but you need to find out what your local unit wants there. Thank you for watching this episode on vitreoretinal referrals. Next time we'll talk about YAG capsulotomy referrals. Thank you.